Welcome to Respiratory Problems. So the main objectives with when you study for the respiratory part of exam 2 will be broken down to the disease. You need to know the main sign and symptom. Some of them will have shared sign and symptom, but every single one has a main sign and symptom, the treatment for the disease, and the education for the patient. First one we're going to talk about is pneumonia. Roughly 1.5 million people a year get diagnosed with pneumonia, and anywhere between 45 and 50,000 deaths occur. So honestly, the main sign and symptom is very mundane. It is what we call pleural pain, where there is a tightness or almost a burning for the patient at the area where the pneumonia is located. Multiple patients can point to exactly where the pneumonia is. Some physicians will require a chest x-ray to establish. Some will do it on history, vital signs, and auscultation because typically you will have some crackles or rhonchi where the pneumonia is located. The treatment is going to be antibiotics. Whether the antibiotics be oral, we send them home, or they have to be admitted because it's a serious case of pneumonia, that would be a patient by patient specific, but antibiotics are the recommendation. Education to complete the round of antibiotics. Okay. Second thing we're talking about is asthma, all right? Asthma. Millions of people in our country have asthmas, both kids and adults. So you're probably already going to know the main sign and symptom is wheezing. Main sign and symptom is wheezing. Half the time you don't even need to auscultate to hear it. The treatment for this is albuterol inhaler. A lot of people will self-treat at home with a home albuterol inhaler. If you ever get one, just keep it. They don't expire for years. Now, side note with the treatment for albuterol. Side note, you're going to want to write this down. The main side effect of albuterol is an increased heart rate. An increased heart rate. So if your patient, either at home and you're doing education, or they're in front of you in the hospital, are taking the albuterol inhaler, and then we typically wait 5-6 minutes or so, and then do another 2 puffs of albuterol. If all you see is their heart rate going up, but there is no improvement on the wheezing or the patient breathing, we need to dig deeper. You may want to ask your physician, tell them what's going on, and be like, hey, we need a chest x-ray done. Unfortunately, the reason is for that is because sometimes it can lead to lung cancer, and there's a blockage, and that's what's causing the wheezing. Sometimes we just need a nebulizer treatment, which has the steroids in them, just to help open up the airway. But regardless, if we're doing the albuterol as ordered and all you see is the heart rate going up and there is no relief from the asthma attack, dig deeper, go farther. Something else besides just straight asthma is going on. Education for this: a patient suffering from asthma should keep their rescue inhaler on them at all times. My husband personally has adult asthma, and we have an inhaler in the home here, and then I carry one with my purse when we're out and about, and he carries one with him just in case. All right, next one, TB, tuberculosis. As much as you would think that this is not something that still happens in our country, it absolutely is. We just don't see it a lot, but that's why we have the negative pressure rooms, or sorry, one of the reasons we have the negative pressure rooms in our facilities. The main sign and symptom is coughing up blood. Treatment. Treatment for this, the most common treatment you're going to see is something called rifampin. If you'd like to know how to spell rifampin, it is in the notes of this slide. Just go take a look. Tuberculosis treatment does tend to last about 6 months to a year, so it is strongly encouraged for the patient to make sure they are taking their doses every single day. If they do not take it every single day, they do risk having to start over. Rifampin is also very hard on the liver, so you're going to tell your patient to be watching for any type of yellowing in their skin, their gums, their eyes, and medical follow-up. It's very common to see an anticoagulation panel ordered, so INR, PT, PTT, because the rifampin can also increase that. So it is something that we do have to watch for. COPD. Main sign and symptom is the patient complaining of difficulty breathing or catching their breath. There's multiple different types of treatments. Short acting is actually typically albuterol, which is what we talked about for asthma. Long acting is salmeterol. Again, both of those are listed in the notes of the slide. There are newer inhalers used for COPD. I'm aware of that. They just aren't quite on NCLEX yet, so we're not going to introduce those, okay? Double check. What ABG would your patient be in if they were suffering from COPD? You might want to double check that you know that. Next one, lung abscess. If you've ever dealt with a patient with a lung abscess, you know, to no fault of the patient whatsoever, you know that they do tend to have really bad breath. But think about it. There is a lung abscess, an infection in their lung that we are trying to treat. So every time they breathe out the infection. Infection typically does not smell good. Regardless if it is secondary or primary, I do not care. We're going to treat it the same way. Lung abscess treatment are going to be a lot of antibiotics, typically IV antibiotics, so they will be going home with a PICC line. And this also could take up to a year. Some patients, it's longer than a year. Education, continue taking the antibiotics. You do need to teach them, because they're going to have that PICC line put in their arm. You need to teach them signs and symptoms of infection in a PICC line. So is the site reddened? Is it raised? Is their forearm in the PICC line arm, did it swell? So you're going to teach them, or teach a family member, how to measure the forearm so they can do it at home. Lung cancer. Now, there's going to be a lot of information on these, the slides for lung cancer. Some of it I'm just going to flat out tell you don't need to know. It's just there because students in the past have asked. You never need to know any statistics for any of the exams or NCLEX, okay? You don't need to know the leading cause of death or how many people are that get lung cancer. They're just on here, okay? You also don't need to know the patho. The lung cancer does have several different types of cancers. They are either under non-small cell or they're under small cell. Again, that is not something you need to know to pass NCLEX or my exams. This information is just there if you were curious. So I'm going to go through these. You can go back and look. You also don't need to know how to stage. Staging any type of cancer is going to be an oncologist aspect, not something that you need to know as a nurse, though if you go into oncology, it will become secondhand. But as you can see on this slide, there are 4 different stages that we utilize for lung cancer. I'm sorry, 5 different stages, my apologies. Earlier the stage, the better the opportunity to go in and take the cancer out and they be cancer free. Typically, by the time we get over to the fourth or fifth stage, it has metastasized at least out of the lung, if not into other areas of the body, including the bone and lymphatic system. Again, you don't need to know the differences between small cell and non-small cell. So, main sign and symptom, and this is one of the reasons individuals don't know they have cancer. The main sign and symptom is a chronic dry cough. Well, it's cold and flu season. We all have chronic dry coughs right now. Do not panic. Don't think you have lung cancer. The treatment with this is going to be a wide variety of treatments, okay? You have what we call the trifecta. You have surgery, chemo, radiation, but you have a lot of sub-treatments. And sub-treatments are going to be physical therapy, occupational therapy, nutrition, Reiki therapy, meditation, oils, dog therapy, music therapy. There's a lot of different aspects going around a patient that is fighting cancer. We just don't look at the cancer. We look at everything helping the patient fight the cancer. Education is going to be a wide girth with lung cancer, so there's really not something specific that I need you to write down, though it is going to be imperative that if you go into oncology, you're going to be put through a lot of empathetic moments that are going to be trialing on you. I speak from experience. Diagnostic studies for these, you don't really need to know those, but if you are curious, we can see lung cancer on chest x-ray. And I have been part of multiple cases in the ER where the patient was in the ER for something completely different, and we took a x-ray and we saw a mass in their lungs. Those patients actually typically have much better outcomes because they weren't suspecting lung cancer at all, and we just found it by accident. CT scans can be done. Lung biopsies need to be done to actually definitively prove, one, that it's cancer. If it is benign or malignant. Malignant means it is cancer. Benign means it's just a tumor that is not cancerous. So if you're gonna have cancer, if you're gonna have a tumor, you want a benign one. And if it is cancer, then it will be able to tell us what type of cancer and have a further aspect of being able to treat it. Some other things that we can do with cancer, and we'll talk more of these throughout the semester when we get into different disease processes that deal with cancer, like a lot of GI cancers. We can do bone scans. We're going to do something called a PET scan. A PET scan is a radiographic scan that we give a patient a certain type of dye, and we put them in this scanning machine. And anything that has cancer cells light up blue in the machine. So when you have a patient that has a PET scan done, the blacker the machine, the better the patient's outcome is. Like I said, multiple different types of therapy. Surgery is the mainstay treatment for lung cancer. If it is still located in the lung, we're going to go take it out. Either that's going to be a lobectomy, where we take out an entire part of the lobe, or it's going to be a wedge, which we're literally going to cut into one of the lobes, and we're going to wedge out the piece of the tumor. If a patient does come with lung cancer, it should be noted for any family, any blood-related genetic family should also be looked at for lung cancer because it is a family trait. So if you have a generation lower, it may be something warranted that is looked for just to be on the side of caution. Health promotion, avoid smoking. Now, it is one of the attributes for lung disease that we want the patient to smoke. And you might think I'm completely crazy for this, but I stand by it. If I have a patient in stage 5 lung cancer and there is no treatment and there is no reversible cause, I actually do not want the patient to quit smoking, because the stress on the body from quitting smoking and going through the detox of smoking actually can end their life faster. So personally, you're probably never going to see this in a textbook anywhere. If the patient can fight the cancer and win, absolutely quit smoking. If they can't, or it's too far in advance, or the prognosis is poor, I wouldn't even mention it to the patient. They have other things they have to do. Pneumothorax. Everybody in Hollywood loves a pneumothorax, okay? So you can have closed pneumothorax, open pneumothorax, spontaneous pneumothorax. You can have all different types of pneumothorax. The treatment's exactly the same though, okay? So whatever happened that caused the pneumothorax, the treatment is a chest tube or some kind of chest tube device. The gauge of the chest tube, what it's called, I don't care about any of that. If your patient does not have lung sounds on one side of the chest and they have their lungs present, which means they haven't had surgery or they weren't born with missing part of a lung, which could happen, as the RN, your first duty is to get the equipment ready for a chest tube placement. We do not put in chest tubes. I don't care how much Hollywood you've watched. A PA, a nurse practitioner, or a physician are the only ones that can put in chest tubes. We are not trained to do it, and you would get in a lot of trouble for trying to do it. But we can be there for the patient. Go get the chest tube, go get the equipment, ask the doc for a dose of morphine, a dose of Versed, which relaxes a patient, and get your patient ready. Be the advocate for your patient. The chest tube is going to have to stay in for several days depending on how bad the pneumothorax is, how the lung is doing. But once the chest tube is in, you should immediately hear lung sounds come back to the chest cavity. You may have diminished lung sounds still in the lower part and the lateral part, but you should you should start hearing lung sounds in the chest cavity as soon as the chest tube is placed. And a physician very often will order a chest x-ray afterwards just to have a baseline of what the lungs look like. Most physicians do not have the time, won't do it. They will not order a chest x-ray before. If you have someone with a pneumothorax, we are on a very strict timeline, and we may not have time for a chest x-ray, but we'll absolutely get one after it is done. Education with this, the patient's going to be admitted to the hospital. We don't typically send chest tubes home with patients. As it happens, sure, but it's not typical, okay? We'll be doing chest x-rays every morning and sometimes in the afternoon, evening to see how the lung is doing. And then once the lung has completely reinflated, then an RN with a physician order can pull out the chest tube. If you have a patient or someone accidentally pulls out a chest tube, and even though it is sutured in place, it can happen, you would have to get something called a Vaseline gauze, and you put it over the opening where the chest tube was, and that will help seal it so you don't get a recurrent pneumothorax. Education with this, for a patient with something called a spontaneous pneumothorax, a spontaneous pneumothorax is a closed pneumothorax, but what happens is the patient hasn't done anything. There wasn't a trauma, there wasn't an accident, nothing happened, and all of a sudden their lung collapsed. And it does happen, though it is rare, and it typically is reoccurrent. So patients will be taught that if all of a sudden this happens again where you just can't breathe, it is a 911 call. We talked about treatment already. Something that is a phenomenon that can happen with the pneumothorax if it is a trauma-related pneumothorax is something called a flailed chest. Now I put a YouTube link here. You can go ahead and look at it. And this is the link for what a flailed chest looks like. A flailed chest is where a patient has 2 or more broken ribs in 2 or more separate locations in the cavity of the rib cage. This phenomenon is called a paradoxal chest movement. So once you watch the video, you'll be able to understand what I'm saying. Couple more videos for it. Different chest tubes. You do not need to know the difference between the chest tubes. Wherever you end up working, you'll have a physicians group that love one type of chest tube. The hospital orders one type of chest tube, and that will be the one that you use, and that's the one that you learn. We're not going to get into the specifics. And in Med-Surg 2, when you do your skills checks off at the beginning of the semester, you'll go through more chest tube education then. Right now, you just need to know a chest tube is for a treatment of a pneumothorax. Different types of chest tubes here. Again, you don't need to know the difference. It's just you're curious. Next one. Everyone likes a good PE. Pulmonary embolism. Pulmonary embolism. This is where there is a blockage of the pulmonary artery, either by tissue or a blood clot. We see more blood clots than anything else, and they typically come from deep vein thrombosis located in the legs. This particular picture is a blood clot. This patient had a autopsy done after time of death was called. And this is a very large blood clot. This particular blood clot is about the size of my pinky. So it is not small. So here's the thing. If you have a patient in the hospital, you might need to listen to what I'm about to say a couple times, write it down. You have a patient in the hospital that have a DVT. So they have blood clots in their legs already. In both legs and one leg, doesn't matter. And all of a sudden, they cannot breathe. 99.9% of the time, they now have a PE from a blood clot, and you need to call a code or a rapid response because you need help. Because this patient needs filters put in, they're going to need boluses of heparin done, and that's not something that you as an RN can do. We need orders for that. These are some different types of vena cava filters that are utilized. You don't need to know the difference from these, and these are going to be physician preference. Whatever they learned on during their fellowship is what they're going to use. That's where the vena cava goes. It prevents blood clots from the lungs getting up into the chest cavity. You don't need to know it, but students get curious. I want to give information. Nursing management. What do? Okay. We are going to be teaching this patient we're going to be teaching them deep breathing and coughing. We're going to be teaching them prevention later. So what's prevention? Prevention, especially if the PE came from DVTs, we need to figure out why. One of the worst cases I ever had for a patient with PE was a wonderful young lady. She was in her mid-20s, had just had a beautiful little boy about a month prior, and presented into the ER with difficulty breathing. She was on an oral contraceptive, and she was a pack-a-day smoker. She had more blood clots in her lungs than the CT, than we could count on the CT. She was put on bed rest. She was allowed to get up and use the washroom, but she was on high doses of heparin to prevent the clots from getting larger, and a vena cava filter was put in, so more clots that if they happen to be, they happen to come from the DVT, from the legs, would be stopped. If it is a serious enough case or the heparin is not doing a good enough job preventing blood clots from getting bigger or new blood clots from forming, there is a medication. It is a clot buster that we use a lot for stroke patients called TPA, tissue plasminogen activator, and that can be used to dissolve the blood clots. So there's a lot that goes into deciding if we're going to use the TPA or have heparin. Could be the severity of the blood clots, the patient's history, but those are the two medications utilized the most. On to pulmonary hypertension. Pulmonary hypertension doesn't get talked about a whole lot. There is a secondary, a primary, doesn't really matter. We treat them the same. Pulmonary hypertension is actually hypertension that is the lungs' fault. There is nothing wrong with the circulatory system. There's nothing wrong with the heart. But for some reason, the lungs have hyperinflated for so long, possibly due to emphysema or COPD or genetic condition, and it causes hypertension to exist in the body. So this treatment, the main sign symptom is going to be shortness of breath along with hypertension. So the patient's going to have both for us to explore pulmonary hypertension. Typical treatment for this when we start is going to be a low pressor, a beta blocker medication if we think it's just hypertension. But once it's established, it's pulmonary hypertension. So lung films will be down, lung testing and breathing testing will be done to establish pulmonary hypertension. And then after that, there is a medication that is incredibly well known out there that was actually designed to treat pulmonary hypertension, but most people do not know it as treatment for pulmonary hypertension. But I can guarantee you've all heard of it and you've seen a commercial for it, and it's called Viagra. Viagra is actually first clinically formulated to treat pulmonary hypertension, and it does a phenomenal job of treating pulmonary hypertension. Pulmonary hypertension is not curable, but it is very well treated with these medications. So when it comes to a disease process like this, because it is not curable, you need to ask the patient how they're feeling on the medication. When I have a patient with pulmonary hypertension, they typically have to give up things that they have liked to do because they couldn't breathe. Okay? The hypertension part is secondary. Pulmonary is the issue here. So what we see is patients have given up things that they love. So a really good example I had a beautiful gentleman come in. He was fantastic. He was in his early 60s, and he absolutely loved to walk his dog several times a day. He was retired. It was just something he loved to do. And his pulmonary hypertension got to the point where he finally did seek medical attention and figured out he had pulmonary hypertension. He thought it was going to be like COPD or emphysema. And his goal was to be able to walk his dog 3 times a day again. That was his goal. I think it's a fantastic goal. It's a measurable goal, and it's a goal he can measure at home without having to call us about it. So he was put on the medication. He came back to my cardiologist about 3 months after the medication was started, and our question to him was, did you reach your goal? If he said yes, I can now walk my dog 3 days a week, or 3 times a day, 3 times a day. I am not short of breath. I am not dizzy. I am not lightheaded. We do not change anything about the treatment. The treatment is working. Don't lower the treatment. Don't increase the treatment. Steady with the treatment and have the patient follow up another 3 to 6 months later, whatever the doctor wants. If a treatment is working for a patient, don't change it. And this is a particular disease process where you have to ask your patient how they feel about the treatment, because you cannot measure someone's shortness of breath for them. Last concept is called cor pulmonale. Cor pulmonale, and we're going to talk more about this when we talk about cardiac, but cor pulmonale is right-sided heart failure because it's an enlargement of the right ventricle of the heart due to pressure that the lung is creating by chronic lung disease. So again, COPD, emphysema, anything like that. These signs and symptoms are going to mimic cardiac right heart failure to the T. We are going to talk more about right-sided heart failure when we talk about cardiac, but I will give you a hint on this particular slide. Look for what ABG will be affected. Look at what the nurse will be monitoring, and look at the most common treatments for it, and all of that is listed right on this slide.